back to our weekly CMR conference series hosted at VCU. We're fortunate to be joined by Dr. Greg Hundley again, who's going to be giving us part 3 of his Basics of CMR series. Just a reminder to everyone that these sessions are CME and MOC accredited, so don't forget to text the code on the screen to the number provided and claim your credit. And for the trainees, the fellows and residents in the audience who want to count some case numbers toward their training numbers, when we do go over cases, you can use that to log your attendance so we can tally those numbers down the road. With that, I'm going to hand it over to Dr. Hundley. Let me share the whiteboard screen.
Yeah. Good morning, everyone. Shannon, can you hear us okay? Anybody? Uh-oh. Can anybody hear us?
Yeah,
Yeah, we can hear you.
Yes.
Okay, great. Thank you. I appreciate it. Well, I didn't want to start if we couldn't hear one another. So let's think about what have we learned the prior 2 sessions very quickly. Okay. Remember, we started with the protons outside of the magnet, right, spinning in a random fashion. And then we go inside the bore, they align their spins, right? And then we have the FM radio wave, and in Richmond, we have TV6, right? And the protons all absorb the energy. And then after the FM radio wave has gone through, back to their orientation in the field, right? And they release energy, and we have the surface coil that picks that up, and we use that to make the picture, right? And we talked about how quickly this process happens, and that's one of the parameters that relates to the T1, and we also have the T2. So we have tissue characteristics on these still framed images. And we talked also about signal, right? From the images, we talked about the pixel sizes, right? And sort of up here, right? The voxel sizes, if it's 3-dimension, it's pixel size if we talk about 2-dimension. And so how many protons do we have in there, right? And that's our signal. And then we also talked about the spatial resolution, right? In the spatial resolution, we had our field of view, right? And then how many lines we're going to put in there, right? And those number of lines, that was our matrix, right? And so if we have lots of signal, or if we have big pixels, like, oops, big voxels, right? Then we have lots of signal, but we have low spatial resolution, right? And if we have little pixels, we have low signal, and we have high spatial resolution. So then after that, we talked about we've got to get temporal resolution. Thank you. Right? Remember this guy? We had to make the movie, right? Over here, making the movie because we had to capture end diastole. And the LV was really large. And then we had to get all the way down to end systole, where the LV cavity is really small. How do we do that? Right? And we talked about when we had a normal regular rhythm, we had these phase encoding groups, right? And we made the line in this interval of time, right? And we make that, and then this part of time goes over and makes this one, and we work through all of that. Remember? And so we had to be able to trigger, right? And it brought into the equation the time interval between these frames, which is the temporal resolution. right? And so we have always three things to trade around: the signal, the spatial resolution, and the temporal resolution. Okay? So now this week, we're going to change and we're going to talk about how do we measure blood flow. Okay? And so Corey, can you bring up a new screen? Because we're going to build on the principles that we learned previously. So first, what does flow equal to? So flow equals area times velocity. Interesting, right? And so we use this, for everyone that works with echocardiography, for everyone that works with images where we're measuring blood flow. What we're trying to determine, right, is if, let's say we've got an image right here, and in the center, we have an axial view. So we have the ascending aorta, and down here we have the descending aorta. What we want to do is we want to know what is the area of this blood vessel, and then what is the velocity at all the different points in here, all the little pixels. What is the velocity within those pixels? And so what's kind of interesting is that with MRI, if within the bore of the magnet, so now over here, we're going to draw an MRI scanner, right? And then here's the bore of the magnet. And what's interesting is within the bore of the magnet, there are these gradients that sit around the outside of that thing. Okay? And what you can do is create a magnetic field gradient so that the magnetic field is low over here and it gets high over here. So high, low. And what's interesting is protons move through the magnetic field gradient from low to high. They accumulate what's called a phase shift. The protons accumulate a phase shift proportional to their velocity. Well, that's kind of interesting. So what that means is you can measure speed. So remember, velocity is speed and direction. So let's go back to our cine movie and how are we going to do that? Okay, so we're going to make our cine movie here. We have up here the idea, the target, and we want to get the ascending aorta. And so we've got to measure it across the cardiac cycle. So we're going to have to go back to our movie making. And rather than just look at left ventricular volumes, now we're going to make a movie of this aorta, right? And the blood flow in the ascending, again, this is an axial view. And we're going to have the ascending aorta and the descending, okay, in all these pictures. And here, just like we had before, we're going to have our QRS thing. We're going to have to tie into this that we've already learned, right? And so we're going to have N diastole, and we're going to have N systole. And we got to measure blood flow in the whole cardiac cycle. So we're going to go all the way back through diastole. to end diastole. So we learned before that to make this picture, we had a phase encode. Remember that? First of all, we got to be able to trigger. Let's put our triggers up here. Not going to worry about the triggering stuff just yet. So we've got nice triggers, nice QRS complex. We're going to have a phase encode. But then in order to come back over here and get this velocity assessment, what we've got to do is create a situation where we can appreciate this higher velocity relative to the background. So what we're going to actually do is take these phase encodes and we're going to make two of them. Okay, so they're going to actually be in pairs. And one piece of information is going to be sensitive to motion. And the other one is going to be insensitive to motion. And so one thing right off the bat, when you start to do the flow measurements, you've taken 2 points in time, this first one here and this second one here. Remember, if we were just doing the gradient echo stuff, and so I'm going to extrapolate that up here, right? Here's our gradient echo stuff. We had one, and then we had another point in time, and another point in time, just like this, right? Well, now what we're going to have to do is take a pair of these, all right? Because we need one of those phase encodes to be sensitive to motion and one to be insensitive to motion. And we get phase maps. And so one key thing to recognize is that TR, which was this time between these two, the TR, see how they're really short? When we're doing the flow, the TR is twice as long. Okay, because we need two phase encodes to make each line of our phase map. Well, to make one phase map and another phase map, but then we have to put those together to get our velocity map. So the way this works is you're going to get a group of these, two of them together, and that goes to make your first row, right? So you can have one here, guy here, and there's our next line, right? But what you need to be thinking about is that your TR, or your ability to get a temporal resolution, falls a little bit because you've got to combine two of these, okay? The same principle, you know, to get the next frame, this comes over here. If we have another pair here, right? That goes here. So we're using the same principle that we used to make the cine images, but to make these velocity maps, in general, they're going to have less temporal resolution, right? They've got about a half of what we had for previous. Now, fortunately, we've gone to the scanner you have on North Ground, this 3T scanner, and not only is the overall magnetic field at 3 Tesla, but these gradient guys over here are really strong, right? And you can switch them really quickly. And so actually, the pair together, it's amazing, is only about 12 milliseconds in time. That's really fast, okay? So we don't lose too much, but it is about half of what we would do for the cine maps. And so you collect these images kind of the same way that we did before. And if you have atrial fibrillation, remember, at AFib last week, and you apply the same thing. So if you've got a nice regular rhythm up here, we still will acquire these with retrospective gating. And then we can switch to prospective gating because most of the forward flow occurs in systole, right? What changes is diastole, so we measure systole the same, and so in AFib, there's nice published studies many years ago, 25 to 30, showing that you can measure flow very nicely with this technology. Now, there are, however, some caveats. Because you start to measure flow, and remember last week, we talked about there were two types of motion. There are two types of motion that we've got to account for, right? So one is the cardiac motion, right? When we're making these pictures, and we address the cardiac motion by doing all these triggers, right? We do the retrospective and the prospective, and we can deal, with all that prospective gating, right? Or the retrospective gating, and we can take care of the cardiac motion because the position of the heart is about the same point in space. But there's another type of motion in the chest when we're trying to measure the aorta or when we're trying to measure LV function, and that is respiratory motion. Okay. Respiratory motion. Now, last week, what we did when we were measuring LV volumes and EF and getting these beautiful cine movies and all that kind of stuff, we held our breath, right? We held our breath for periods of about 7 seconds. And we did some phase encoding grouping and all that kind of stuff, root these things together so we could get a whole bunch of lines at one time and all that, and fit everything into about a 7 or 8 second breath hold because we were able to take care of the respiratory motion with breath holding. But what you've got to be careful of if you're measuring blood flow is that someone doesn't take a big breath in and then hold it and bear down and have a Valsalva maneuver, right? Because what's going to happen? Well, you're going to increase that thoracic pressure, you decrease venous return, and you can make the cardiac output, which is what we're trying to measure right here, go down if someone has a Valsalva maneuver. So we have to do one of two things to take care of the respiratory motion artifact. One, we can do the breath holding, but if we know that our study is going to involve flow calculations, then what we have to do is coach. We have to coach the patients to make sure that they don't have a Valsalva maneuver when they're holding their breath. And that's kind of tricky sometimes because some people just can't avoid that, especially when they get up inside the bore of this scanner, they get nervous and they may even forget. So if that's a consideration, so number one, A, was breath holding. B is something we didn't talk about last week, and that is respiratory triggering. What in the world are we talking about here? Well, on the backdrop of these nice QRS complexes, and here we're going through our AFib example here, you can also do one of several things. You can put on what's called a respiratory bellows, or you could put on a way the scanner can track the diaphragm during scanning, and you can track the respiratory motion throughout your image acquisition process. And what you end up doing is when the heart is in one of the locations, either at end inspiration or at end expiration, pick one of the two, that's going to be the period of time where you collect these images related to the organization around the QRS complex. Okay. So now that is going to take a long time, right? Because let's say we're doing end expiration, you collect these points in time. And then when the diaphragm starts to move or the bellows starts to change, you throw this away. And you don't start collecting again until you get back to this nadir when the heart is in the same position. So when we're using respiratory triggering, those are not going to be 8-second scans, right? Those scans are going to take maybe 1 to 2 minutes so that you can collect enough of these phasing codes to make your movies over here, okay? So one of the things we have to think about when we're doing this flow measurements is we've got to get and think about the respiratory motion and how we're going to address that, okay? All right, let's go to new screen. Thanks, Corey. So let's go back to now our aorta. Here's our aorta here. Here's the descending. Remember, we have the axial image. And so our flow is equal to the area times the velocity. And if we take this image, and I'm going to change colors. And remember, we've got these lines going through here, right? To make our images. Now they're in blue on the screen. I'm going to make some bigger ones because I'm not going to draw 256 of these things. Remember, we've got them in 2 directions, right? Trying to kind of space these things out. They're all supposed to be equally spaced.
Yes, I will.
Okay. So the next thing, how are we going to do our flow calculation? Well, what we're going to do is to get the area, we're going to trace this boundary, right? And remember, we know the size of these pixels in here because we know the matrix. So we know how many lines are in here, right? And we know the total distance, the field of view. So by knowing the field of view, and let's say that's 36 centimeters, and then we have 256 of these lines in here, we can divide and we can get the area of each one of these pixels. And when you draw a region of interest, what it's doing is it's saying, okay, how many of these pixels do I have in here? And what are their respective area? And so it's basically the number of pixels times the pixel size, right? And that gets you the area. Okay? The other thing you do, and you'll see when you do these images, you're going to get these velocity maps. And the velocity maps are going to have a grayscale. And the level of the grayscale encodes for speed. Okay? And so let's take this little part of the aorta, bring it down here. Here's our aorta here. We had all those lines going across it, right? And you're going to have you're going to have white, which will be the most negative, and then you'll have dark black, which will be the most positive, and then gray is going to be 0. And essentially, what happens, you draw the region of interest, and it knows the size of the pixels, and you know the number, so that gives you the area. And then each one of these pixels is going to be shaded some level of gray, and that's going to give you a velocity measurement. So what's advantageous about this method to calculate blood flow is that you get the velocity at every point. Give you a new color. You get that velocity at every point within the lumen, right? And that's why this becomes the most accurate way we have today to non-invasively measure blood flow. If we're doing echo, what does echo do? Well, echo is a beam. Go back to red. Echo is a beam that goes and measures the highest velocity and assumes parabolic flow, and it estimates what all these other pixels are. Okay? Whereas with MR, what it's doing is accurately measuring the velocity in every single one of these. And so you get a very true assessment of the velocity across all of the pixels contained within the lumen. So very precisely can you measure velocity, and very precisely can you measure area, and that's how nicely you can get flow. Now, there are, again, more caveats. And remember what you have, remember the phase encodes? Remember these guys? So you had this guy and this guy together, right? And so one of these is set so that everything's going to be 0, and this other one is set to measure this dynamic range of velocity from the most negative to the most positive. Okay? You put those two together, and then you get the velocity in this area, what's moving, and we're going to talk about the different planes in just a second. And we'll assume this is through plane flow in and out of this whiteboard. And so very nicely, you can measure the blood flow and the velocity. Okay? Now, there's some tricks that you have to know when you're doing this. Not tricks, but facts you need to know. The first thing you've got to know is you've got to set the range. You've got to set the range of the velocities that you're going to measure. So in this example, maybe it's plus 2 meters per second. And over here is minus 2 meters per second. Okay? What is the normal velocity in most of the blood vessels that we're looking at? About a meter per second, 0.75 to a meter per second. So you've got to be thinking about what is the question that I want to be answering so that you set the correct velocity range. Let's use an example. I've got 3 speedometers. Okay, 3 speedometers. This speedometer is, if you've got children, is on your tricycle. This speedometer is on your car. And this speedometer is on a spacecraft. So this tricycle probably has a speedometer that might go to 15 miles per hour. The cars today, it's roughly 120 miles per hour. And the spacecraft is 20,000 miles, maybe 100,000 miles per hour. Okay. And so what's important is that when you think about measuring blood flow with MRI, you have to be thinking about the range, because if you put the tricycle speedometer on a car, what's going to happen is you start here and you're going to go around past the positive, and it's going to wrap and come back around the negative. And that is called aliasing. So one of the problems that you have when you pick this speedometer that's set too low for the target that you're imaging, you're going to have aliasing. Okay? Because the car is going 120 miles an hour, and this speedometer is just going to go, wee, right? You're going to wrap it around a gazillion times. So this speedometer does not work on this car. Now, what happens if we put the space shuttle speedometer on the car? Well, it's set to go from 0 to 20,000 miles per hour. And so what happens there is, if this is 0, it's moved almost none. And so you don't capture the true velocity. So when you're thinking about measuring blood flow, you have to anticipate with MRI what your velocity range is going to be. And if you don't do that correctly, you don't have the right dynamic range, you're not going to correctly, you got this beautiful technology, but you're not going to set up the ability of the scanner to appreciate the information that you seek. So where does that come up? We're going to talk about that in a minute. But think about, I want to measure the peak velocity in aortic stenosis. Well, if I set the velocity range to 2 meters per second, I'm going to have aliasing. Because severe aortic stenosis, we might anticipate that velocity to be 6 meters per second, right? If we set the velocity range to be 20 meters per second, then we'll be in this situation where we don't accurately measure the velocity because we won't be able to detect it very well, okay? It's not moving enough along the dynamic range in order to appreciate a difference between 16 and maybe, well, let's say 14 to 20, right? It just can't separate that for you, and that could be clinically important information. Okay? So, what were some of the things we have to think about when we're measuring blood flow? One is we got to now deal with our respiratory motion. We got to plan for that. Number two, we've got to be thinking about our temporal resolution is going to be cut, right? Because we have, instead of one phase encode, right? We have two, right? Because we need a phase sensitive and one that is not phase sensitive, or that one that is one sensitive to motion and one not sensitive to motion. Number three, we've got to think about the dynamic range okay, of what we're doing so we don't have aliasing down here, and then also so we don't make the correct measurement. There's a fourth thing that we have to think about. And, I drew for you that whole phase encode thing. Remember? So we have one that's not sensitive to motion and one that is. But that one that is only in one direction. Right? And so you've got to think about also when you're doing flow measurements is the direction. And so you have opportunities to think about that. And it can be in one of three directions, right? It could be through the plane, in and out, but it could be left to right or anterior to posterior. So you need to remember, and that's going to be relevant. Let's say you've got a patient with a suspected atrial septal defect, right? Let's draw our heart here. Here's our RV, here's our LV, and we want to know, is there blood flow going across here? Well, if we set the phase encoding direction this way, we're not going to see it. Or if we do it through plane, like we're doing for the blood vessels right now, we're not going to see it. It needs to be set left to right. And there is one little trick here. You can add more of these, right? You can add a in-plane left to right, in-plane AP, and a through plane superior to inferior, but you're going to dramatically cut the temporal resolution and take a much longer time to get those images. Remember we talked about with the respiratory triggering and all that kind of stuff. So importantly, you've also got to think about the direction, how you're aligning this technology. Is it through plane, like we're doing over here with the aorta, or is it in plane? And if it's in plane, in what direction is it in plane? Okay, so we have things to think about when we're doing this flow measurement stuff, and it is very accurate. All right, let's get a new screen. So let's finish with some practical uses of flow measurements, okay? And so I'm going to draw for you right now, quickly, putting in here left atrium. Oops. Mitral valve in here. Hit the pencil up there. Got it. The Here's our aorta. Here's our pulmonary artery. Here's our RV. Here's our pulmonic valve. Tricuspid valve. Mitral valve. So let's think about how we might be using this flow stuff. So one of the key ones is mitral regurgitation. So we have a jet right here, right? So when we think about mitral regurgitation, what do we want to do? We want to know, is it present? We want to know its mechanism. We want to know the magnitude of the mitral regurgitation. And we want to know its impact on LV volumes. Right? If we know these things, then we can make an informed decision. So one of the ways we can go and look to see if this is present is we can do, there are two white blood imaging techniques. Now, I can't remember if we mentioned them last time, but one is called steady state free precession, and the other one is called gradient echo imaging. And what you need to know is that if you're looking for these jets, you want to focus on gradient echo imaging, okay? That's the one that, we'll talk about that another time. We don't have a lot of time here, but that's the one that allows us to appreciate the jets and determine whether they're present. The mechanism is taking a series of those gradient echo images in different planes. Right? We're trying to decide, is it primary mitral regurgitation? Is there mitral valve prolapse, whatever it is? Or is there just LV dilation and it's secondary? That's nice. Then here, we want to know the magnitude. Well, that's where you come to the rescue with your flow measurement techniques. There's two ways that you can determine the magnitude. One would be to put an imaging slice right here across the mitral valve and measure through plane flow. Okay, so that's one way, but I don't rely on that as much because this mitral annulus moves a lot back and forth. Okay, so another way to do it is to say, okay, let's take the cine images that we got last week. Okay, and let's get a stack of those. This is kind of a neat thing to do. We do this in almost all the cases. Gonna keep on going here because we got to get all the way up to this aortic valve. So we get a stack of these cine slices, and from that we can get the LV-EDV and the LV-ESV. And we can subtract those and get the LV stroke volume. Now, the problem with that issue in this situation is, where's that stroke volume going? Well, part of it is going this way through that regurgitant jet, and the rest of it is going right out here into the aorta. Okay? And so what we've got to do is figure out which proportion of that stroke volume is going to the left and which is going to the right. So we can do that by making a flow measurement right up here in the ascending thoracic aorta and measuring through plane flow here. So what you can do to get the regurgitant volume, you can get the LV stroke volume, and you can subtract the forward flow in the ascending aorta. And generally to do that, you want to be 4 centimeters away from this aortic annulus. Okay? So very nicely, you can calculate the regurgitant volume and the regurgitant fraction. And oh, by the way, by doing that, you get a bonus, because in order to decide what you're going to do about this, you need the impact on the LV volumes. Well, you've gotten all that because you did this. Right? So very nicely, you can do an assessment of mitral regurgitation. You can also do the same principle for aortic regurgitation. You can measure LV stroke volume total, and you can measure forward, and you can subtract, and you can get the regurgitant volume this way. When I do that, I also will put a slice plane here, just like we did with the mitral valve, because I like to do it both ways and just compare them. So it's a really nice way to measure these regurgitant volumes. Now, suppose we've got aortic stenosis. Well, here we can take our, remember now we've got a high velocity jet going this way. We've got to remember, what are we going to set our velocity encoding to be? What velocity range, plus or minus, probably 6 meters per second or something like that. And you can dial this in with the technologist, and then you can measure the peak velocity across that aortic valve. Going back just 1 second, remember, people will forget this sometimes. If you are measuring this regurgitant velocity here in the setting of mitral regurgitation, that velocity is generally very high. Why? Because you've got a high pressure emptying into a low pressure conduit. And so these velocities, they go up to 9 meters per second, right? So this MR jet, same thing over here if you get with the TR jet. You know, you see this in echo. You've got your transducer over here, and you're trying to decide, are you in this AS jet, or are you in this TR jet, and all that kind of stuff, okay? So just keep that in mind. Very nice technique for getting that peak velocity. And you can also get that same peak velocity, as well as look at the images and get either regurgitant orifice areas or stenotic areas using all of these methods, okay? So in summary, today, let's go back. Did any of these say?
Yeah.
Oh, good. Maybe go back to. Yeah. So we're going to use, we have a very nice, elegant technique to measure blood flow, because flow is equal to area times velocity. And to do that, we're going to dive into the world that we used to do the cine imaging. Remember, we got to make a movie of this stuff. See over here, this nice long line, right? And then what we're going to do is use our same old phase encoding up at the top left, But remember, our temporal resolution is cut because we're going to make one phasing code insensitive and one phasing code sensitive to flow. We're going to be thinking, and so we make this nice movie, and we can calculate the blood flow by looking at the area, and then we get all the velocities that are within all the pixels right inside the blood vessel. Very nice. We have to be thinking about a couple things when we do this. One, we didn't spend much time, but we always want to be cognizant of the respiratory motion when we're doing this. How do we want to account for that? So if we've got a flow study coming up, we've got to be talking to our patients to make sure that they don't have a Valsalva maneuver. Because if they do, we're going to decrease preload and our flows are going to go down. Another technique, which we did not talk about last week, because we weren't that interested in it, with just the cine imaging, is we can use respiratory triggering. And remember, you're going to capture at some component of the respiratory cycle, and the image acquisition is going to take longer. Now, the patient's not going to hold their breath, but it's going to take, 1 to 2 minutes. Next slide. So then we talked about our respiratory motion, which is right here. We've got to think about our temporal resolution. Our temporal resolution is going to go down, and we're going to always be trading that also with the same principles apply, our signal to noise and our spatial resolution, right? It's always a balance with that. When you're doing this kind of imaging, you've always got to set the dynamic range. Think about these speedometers. We got the space shuttle, the car, and your child's tricycle. If you take this space shuttle thing and you're all excited and you take it home to your 4-year-old son and you stick it on this and they pedal their little hearts out and that thing doesn't move, they're sad. Okay? So you're going to be sad if you're up here being a medical person and you pick the wrong one of these. We've talked about why. Either you get the aliasing because you make the thing spin around, or you don't set it so that you can actually even appreciate the right amount of velocity. Okay? So if your child's sad, you're sad. So we got to get the dynamic range. And then lastly, we've got to set the direction. Okay? If it's going to be in plane, which direction, depending upon the jet that you want to look at, or is it going to be through plane? Now, one thing we didn't mention, how many pixels do you need in the lumen to actually measure the blood flow action, perfectly? Does anybody know? 16. So when you're setting your spatial resolution, depending on the target, you need at least 16 of these blocks in order to make an accurate velocity measurement when you're doing flow in these blood vessels. Next slide. And then lastly, we talked about how we might use this methodology, right? And so we might use it for regurgitant volumes, AI, MR, going this way. We can use it for stenotic lesions because we're measuring these peak velocities and things like that. And so just keep that in mind. That's how you do it. Anytime that I look and I'm trying to calculate or think about mitral regurgitation, is it present? What's the mechanism, the magnitude, and then impact on LV volumes? You're going to use the gradient echo technique to determine if it's present. You got a lot of different imaging planes to help with the mechanism. The magnitude, through plane flow, make sure you got enough pixels and voxels and all that stuff. And then always use a check. Don't just put one slice here, right? Also do your check, and you got to do that anyway with all these other images and slices because you've got to get the impact on LV volume. Okay, so that's about it for number 3. I think, Corey, next year we need 4 because we didn't get to the perfusion, right? We haven't talked about that and all the different methods.
Let's do it. Yeah, okay. Thank you so much. Let's see.
Can one quantify the amount of flow within plane? Yes, but you've got to have an analysis. So you can collect it, but you've got to make sure you've got an analysis tool to do that. And where do we use that? Very frequently. We use that when we're measuring something called pulse wave velocity. So that's this change in velocity. I didn't draw the aorta here. It goes way down here behind. And so we're measuring the velocities along different points and the distance of the change in those velocities over the cardiac cycle when we do pulse wave velocity. And do you consider coronary flow when you measure flow above the coronary ostia and the AO comparing to the LV stroke volume? Yeah, you can. People originally, the question is right in this area here, where we've got the coronary arteries coming off, right in here and right in here. Now, you can get a pretty sophisticated high spatial resolution image and actually measure the flow and measure the flow reserve, and spent a lot of my career doing that. In terms of this forward flow and then using that to calculate the coronary flow, that was first done back in right around 1982. We don't use that method anymore. And then lastly, a part of this question is, do we try to account for this when we're measuring these forward flows and all that stuff? And generally not. That flow, if you look at, can we get a new screen? Sure. If we get flow in the aorta, okay, so I'm going to draw you time. I've spent a lot of my life doing this kind of thing. A little bit nutty. But anyway, here's the flow. So this is normal flow, okay? And basically, in order to calculate, you're going to have images. Let's put our little images down here of the aorta. This is the ascending aorta. We're collecting these images over time. We go all the way out here. So here is most of the systolic flow. And that's going to make up the majority of the forward flow. There's a tiny bit out here in diastole, but not very much at all. Trivial. And what you just brought up, the guy, whoever asked the question, this is the coronary flow. Right there, that little piece. And it's really negligible when you're doing this relative to all of this and this. So we just don't, it gets factored in to the calculation, but it didn't turn out to be very much. Now, when you have aortic regurgitation, make a new color, make that black. What happens is this flow curve looks like this. Okay, and you got all this flow down here when you have a lot of aortic regurgitation. Okay, so anyway, good question. That's this particular area. It gets factored in, but in the big scheme of things, it doesn't contribute much to the forward flow. And then secondly, when this was first developed, it was used to calculate coronary flow reserve or coronary flows and flow reserve, just measuring this little thing in the aorta. But since that time, what's happened is there are techniques today, and have been around for 30 years or so, where you can actually put one of those slice planes right here along the coronary artery, perpendicular to the direction of flow, and you're just fine. So, okay.
That was great. Thank you so much. And
Yeah.
Appreciate everybody joining. And Shannon, if you don't mind throwing up the CME slide, and then we'll see everybody back next week.
Thank you.